Well, good morning, everybody, and welcome to the Osher Center for Integrative Health Grand Rounds. My name is Peter Wayne, and I serve as the director for the Osher Center. Today, we're privileged to have Dr. Gert Bronfort present on a topic that he's recognized as a world authority on, namely a biopsychosocial or a holistic approach to treating back pain. But before introducing Dr. Bronfort, a few practical matters. So first, as many of you can recognize here, we've adopted a new Zoom platform for our grand rounds that we hope is a bit more interactive. It allows us all to see one another in the group view and during the Q&A for a handful of you to ask your questions directly. But for this to work smoothly, we ask the following of you. Please remain on mute during the entire presentation. If you wish to exchange general comments with other attendees during the presentation, please use the chat feature. If a question emerges during the presentation that you want the speaker to address, please type it in the question and answer or Q&A feature. I'll be curating these and will present them to Dr. Bronfort in the discussion following his lecture. And if you wish to ask a question directly during the post-presentation Q&A, please use the raise hand feature. Finally, if you wish to request some CMEs, email us at this address here and include the following requested information. So now it's my distinct pleasure to introduce our esteemed guest today, Dr. Gert Bronfort. Dr. Bronfort is a research professor based in the Integrative Health and Wellbeing Research Program, which is part of the larger Earl Bakken Center for Spirituality and Healing at the University of Minnesota, which is one of the first centers committed to integrative medicine in the United States. For more than 30 years, Dr. Bronfort has been a leader in research investigating conservative and integrative care for disabling and costly musculoskeletal pain conditions. Dr. Bronfort received his doctorate of chiropractic from the Canadian Memorial Chiropractic College in Toronto and his doctorate in extramural medicine from Raha University in Amsterdam in the Netherlands. Dr. Bronfort has been a key proponent of interdisciplinary collaborative research and has formed numerous regional, national, and international partnerships to conduct innovative, high-impact, patient-oriented research. He has led numerous federally and NIH-funded randomized clinical trials investigating manual therapies, exercise, self-care, and he's authored over 100 peer-reviewed articles, including several very high-profile systematic reviews. Dr. Bronfort is a long-standing and active member of the Cochrane Collaboration's Low Back Pain Editorial Group, as well as its Cervical Overview Group. And we know that the Cochrane Collaborative is sort of the state-of-the-art in terms of evidence collation. He served on several national and international committees, including the Advisory Council for the former National Center for Complementary and Alternative Medicine at NIH, the World Health Organization, and the U.S. Health Resources and Services Administration's Advisory Committee on Interdisciplinary Community-Based Linkages. I know we're in for a really special treat today, so without further ado, please join me.
Well, thank you very much for that nice introduction. Peter and I know each other well from trials that are currently ongoing that Peter is involved in monitoring. So without further ado here, I'd like to get into my presentation. I've chosen to call it Individualized Biopsychosocial Assessment and Treatment of Back Pain because that's currently where we are at with our research focus. And it hasn't always been like that. And I'll give you some examples of previous trials where it's more monotherapeutic approaches and then leading into combination treatments and then eventually into the basis for providing biopsychosocial assessment and treatment of back pain. About our team, it's a professional, diverse, multidisciplinary team, early to late career faculty and non-faculty scientists, and they represent a number of professions, as you can see here. We are currently maybe about 15, 16 people full-time, And then there are several part-time people, and that changes all the time. We're bringing in new people, but most of them are still associated with our program. A little bit of our success in terms of attracting funding. We started our program actually at Wolf Hare Center for Clinical Studies, a smaller university in Bloomington, and eventually got success with attracting federal funding. And then we transitioned into the Bakken Center for Spirituality and Healing University in 2014. And since then, we've been fortunate to receive more than $20 million in federal and NIH funding for our trials. And including in that is a almost $2 million in philanthropic support from NCMIC's Research Foundation. So here's our focus. It is currently, and obviously has been for a long time, a whole person focus, or especially using interventions like pain education, exercise, mind-body therapy, spinal manipulation, and health behavioral change and self-management, primarily for spine pain related conditions, including headache. Let's look at what currently the clinical guidelines in the United States are advocating. And if we look at something that changed a few years ago was a focus away from pharmacological treatment as the first line of treatment for back pain, for and basically saying only in patients that have inadequate response to non-pharmacological therapy, you should consider pharmacological treatment. In reality, it's probably going to be a combination of both types, pharmacological and non-pharmacological treatment that's required for most people to manage their back pain. Some of these treatments are that have been identified in the clinical guidelines are manual treatment, spinal manipulation, cognitive behavioral treatment, exercise, supervised or non-exercised, and Pilates and other types of mind-body therapies. So the evidence of monotherapeutic approaches to treatment of back pain. This is the backdrop from where we started, and is still probably relevant and fairly accurate. And so these are some of the prominent researchers that have both done clinical trials and also systematic reviews. And you can see here that symptom improvement is similar in patterns in clinical trials following a wide variety of active as well as inactive treatments that you would think would have majorly different mechanisms of action. And so much of the apparent benefit of treatment for back pain are likely not due to specific effects of the intervention. And your own Kapchak has also identified that these non-specific effects can produce statistically and clinically important outcomes, and the patient-practitioner relationship is the most robust component. And finally, DO has called for backing off of treatment with things that are only marginally effective. So if we just look at the evidence for two of the physical treatments that we've been using, spinal manipulation, what you see here is that there's short-term benefit in terms of pain and function, which is disability, when compared to other recommended treatments. So there might be a slight edge at one point with these, but basically with spinal manipulation, but basically it's not much different in terms of effectiveness compared to the other recommended treatments. If we talk for a moment about the risk associated with spinal manipulation, there's been a lot of reviews. You can see nearly 300 reviews, and most frequently described adverse events are stroke, headache, and vertebral artery dissection. At one point, about 10 years ago, I was asked together with a couple of other people of should we abandon cervical spinal manipulation for mechanical neck pain? That's obviously the condition that's mostly concerns us in terms of serious adverse events. And so what we were basing our response on was that Cassidy was using the Ontario population over 9 years, over 100 million person years, and confirmed that there was a strong association between chiropractic care and subsequent vertebral stroke in people under 45 in both case control and case crossover designs. But what was important here was the similar association was found between family physician care and vertebral stroke. So the conclusion was that this is confounding by indication. In other words, people are under development of a stroke, and then they go and see a provider of some type. And so that's why we said there's no basis for abandoning cervical spine manipulation. The other major intervention that has a lot of evidence behind it is different types of exercises for back pain. And we now have a very sophisticated network meta-analysis. Remember, meta-analysis is usually looking at one treatment and one comparison and then summarizing all of that. But in network meta-analysis, that's a newer technology that is gaining popularity. You can compare all kinds of different types of exercises with each other, and other types of treatments like aerobic treatment and this review identified that Pilates, McKenzie exercise, and functional restoration were probably the most effective using this sophisticated review. But nevertheless, patients with chronic low back pain should be encouraged to perform the exercise that they enjoy the most to promote adherence. So here are some examples of previous trials. Here's a study that we did, published in the Spine Journal a while back, comparing supervised exercise, spinal manipulation, and home exercise for chronic low back pain. So 3 individual approaches in about 100 patients per group in adults 18 to 65. So all treatment groups improved over the 12 weeks, but they did not significantly differ in terms of pain and other patient-rated individual outcomes in either the short and long term. So it kind of confirms that 3 different types of treatments are very similar. The small differences you see here were not statistically significant and were small in effect size, and we were adequately powered with 100 people per group. We then did another randomized trial focusing on older adults, 65 years and older. And here we did some combination therapy, spinal manipulation with home exercise, supervised exercise with home exercise, and home exercise alone. And again, we see some reduction over time, but we have to conclude that adding SMT or rehabilitative exercise to home exercise alone does not appear to improve pain or disability outcomes substantially in either the short or long term in older adults. We then turn to a younger group of back pain, chronic back pain patients. Very little research has been done in adolescents, but low back pain develops with increasing frequency in adolescence, almost reaching the same prevalence rates that you see in adults in the late teens. And it's been shown to be a strong predictor of back pain later on. And so another interesting thing is that between 20 to 40% of U.S. adolescent back pain sufferers receive opioid prescription when they seek medical care. So this study was in 185 patients, about 90 in each group. And so for adolescents with chronic low back pain, spinal manipulation combined with exercise was more effective than exercise alone over a 1 year period, with the largest differences occurring at 6 months. And and you can see when you look at here, the pain severity in the beginning, 12 weeks of treatment, wasn't that much difference. It was probably half a or 5 percentage points at that point. But then later on, much to our surprise, you usually don't see that in trials. There was a bigger effect that was somewhat sustained over time. And so when we look at this, we look at the whole period of time when we analyze it, and that's why that was predetermined. That's why we could say that these adolescents, when combined with spinal manipulation and the exercise program, was more effective than without spinal manipulation. What we like to do in our trials, and I'll get back to that a little later, is we like to present responder analyses, because that's how clinicians and patients can actually better relate to the outcomes of trials. When you just look at the mean differences, it doesn't tell you very much about the underlying population. So I'll get back to that in a moment. Then we also did a combination treatment here, home exercise or device, alone or in combination with spinal manipulation for chronic back-related leg pain. And if you look at the time points here, those two graphs are pain and disability. And we can see over time that people are doing better in the combination group. And the conclusion was that spinal manipulation with home exercise improved self-reported pain and function alone at 12 weeks, but differences between groups were not present at 52 weeks, except for some secondary outcomes. The combination therapy turned out to be successful here. Then we tried to look at the possibility of comparing multidisciplinary integrative care with chiropractic care as it's normally performed by chiropractors. So the chiropractic care group had 100 participants. It was delivered by 3 chiropractors, and they used what they would normally do in chiropractic care. There would be some teaching of exercises that's normally done. But then in the multidisciplinary integrative care group, there are 6 different provider types: acupuncturists, chiropractors, psychologists, exercise therapists, massage therapists, and primary care medical physicians, with case managers coordinating the care delivery. And there was a high degree of interaction with patients in terms of preference of what they were. Once they were randomized, there was some negotiation with patients of what they would most likely think that they would benefit from, and that guided the intervention plan. And the results show that the integrative care was slightly better in terms of both pain reduction and disability reduction. And you can see that from the left and the right graph there. And again, we did some responder analysis, and what you see there is there is a much higher percentage of the integrative care group, that higher proportion of patients that have 20, 40, and up to 50% improvement. This is another study that's been completed and is being reported on in journals. This was a group of people 50 years of age or older where mindfulness training, mindful movement was compared to another well-being program that did not include the mindful movement. And it was a community-based randomized hybrid effectiveness implementation trial. And the main outcome was how much improvement in moderate to vigorous physical activity could you gain by comparing these two groups. And what we see, it should be the background is really the average for US adults in the age range that we had in the trial here was 87 minutes per week. And you can see that the participants started off much lower than that, about 20 minutes per week, and then improved substantially, and especially in the mindfulness movement group. And so we could conclude that even those are maybe small differences, they are important differences and they were statistically significant. Another just completed trial that our group was involved in, principal investigator psychologist from the Veterans Administration in the Twin Cities, looked at comparing self-paced mobile mindfulness program with either with or without a group intervention to usual care. So everybody were allowed to continue with their usual care. So these two groups were added on top of it. And what we see here is that both of them were doing better than usual care. These differences are rather small, but I think to the Veterans Administration and for the investment and access of this becomes important for implementation. I talked before about how do we define what is clinically important in randomized trials? It's a big issue for trialists, and there's been all kinds of attempts to have a quantitative measure. For example, some people would say, well, 10 percentage point difference on pain is probably not clinically important. And that's been carried from trials into systematic reviews. And the reality is that this is too simplistic a way of looking at what's clinically important. If you look at the two graphs on top, that's actually from one of our trials, the trial on adolescents for chronic back pain. And again, it depends on whether you choose a predetermined time point, which is often done in clinical trials. Our preference is to look at the whole experience, have a long enough follow-up period. And if you look at that, you can see that at the end of treatment at 12 weeks up there, the difference is not very big. And then it gets bigger with time. And if you look at the whole trajectory, there's a clear advantage that's both clinically important and clinical significant. And again, the cumulative responder analysis helps a lot to see how big a proportion that would get 20% improvement. If you look at that graph up there, you can see probably about 75% get 20% improvement and about 50%, 40 to 50% improvement. So that tells you something about the chance of getting better under those different treatments. So what's important here is to distinguish between what's clinically important for the individual patient and what's clinically important in terms of group differences. They are often mixed up and frequently understood. So here are some guidelines for what should be taken into account when you look for clinical importance. Should be obviously the magnitude of group differences, but also proportion of responders, the consistency of primary and secondary outcome measures, the durability of treatment, the intervention safety and tolerability, access and cost, and participant adherence to treatment. All those should be factored in to when you may discuss the clinical importance. The example here clearly illustrate how big a distribution difference there could be. You look at these are the means for three arbitrary outcomes, or from some arbitrary outcomes in a trial. And so you have maybe a 10 percentage point difference between this group and this group. But when you go to apply this to the individual patient in front of you as a clinician, this is really what you're looking at. That's the distribution. You have no idea where that patient will fall. You can just say, well, on average, this seems to be a good thing. And then that's where a more individualized approach comes into play. So within the last, I would say, 5 to 10 years, our trial focus has shifted to pay a lot more attention to the dynamic biopsychosocial model that's been redefined by Lehman and her colleagues, um, and is now based on a more systematic approach and a systems approach for how these different components interact. And the other major framework that we're using is the behavioral change wheel framework that is a synthesis of 19 existing behavioral change frameworks, and probably the most comprehensive of the frameworks, and with up to 100 different types of behavioral change techniques. And so our team's work is still focused on randomized trials, systematic reviews, and increasingly with focus on community engagement studies. We have done a fair number of cost-effectiveness studies, and usually there's mixed methods involved in terms of quantitative and qualitative elements. So this is the dynamic biopsychosocial model that's been expanded, especially in defining the interpersonal, community, and social cultural elements of the biopsychosocial model. The biopsychosocial model was introduced many, many years ago, and later on by Gordon Waddell for back pain, but it wasn't really implemented. I remember we had meetings about 10 years ago where we had to basically say, well, there hasn't been much implementation of that model into the research, and this is now happening more and more at this point in time. And just to give you a little bit of example of how we address patients' biopsychosocial and well-being needs, we attempt to increase their knowledge of back pain and what the nature of low back pain is, understand the basis and mechanism for experienced pain, and then we put emphasis on skills to ability to self-manage with physical exercises and mobility and stabilization, and then also psychological strategy, relaxed breathing, progressive muscle relaxation, cognitive behavioral changes, and then ability to navigate social and relationship roles. And then the motivations are then affected by different behavioral change techniques that we try now to tailor to the individual patient in terms of education, skill training, enablement, persuasion, and with the support information they have, website, digital recordings, videos, and so forth. And this is an ongoing trial that uses this particular approach. It's in a community-based NCCIH-funded trial, but also part of the HEAL initiative that many of you may have heard of. And there are two phases here: an initial feasibility in 40 patients that is now completed, and we are about to ask for the transition request, and we've shown that it's feasible to actually record these patients, which are at this case in this particular trial have to be members of racial and ethnic minority groups, Black, Indigenous, people of color, and have household income or have household income of less than $50,000. Those are typically not recruited for clinical trials, and we've had difficulty doing that, but have now had much success with partnering with community leaders and facilitators. And so this is a self-management program for people that have back and neck pain. There are no clinicians involved. This is all facilitated by lay people that are trained to provide this kind of information. And it should have a good chance of transition into a full-scale trial where we look at 376 patients that are randomized into one or two conditions. Primary outcome is pain intensity interference, self-efficacy, physical function, and so forth are secondary outcomes. This is another feasibility study that was based on our previous trial on spinal manipulation for home exercise with advice for chronic back-related leg pain. And here we are comparing back-related leg pain patients with or without neurological signs, divided into two groups: medical care as they would normally be managed, but it is evidence-based medical care that is provided within the trial. And then there's supportive self-management, which builds on a lot of these principles that I've just outlined for you. So there's a 6-month follow-up, weekly and monthly surveys was done, and this also turned out to be feasible. And we're now working on an extension of that to a full-scale trial, which may use a UG3, UH3 mechanism, and we need to then involve more sites to take it to that level, and that's what we're working on right now. This is a busy slide, but let me give you a little bit of a sense of how we look at summarize individual patients. So this is an example from a patient where we take some of the most salient and important parts of both the biophysical, psychological, and social components, and then we have a fairly simple scale and rate them from 0 with no problems in that area to 3 with substantial problems. And that then guides both in the biophysical, psychological, social realm, guides what kind of individualized patient plan we come up with. And below you see, again, some of the different components that we would choose based on the patient profile. And part of our framework is, of course, what we talked about before, the COMP-B needs, the capabilities that patients have, opportunities, motivation. So that's going to be factored into the behavioral change techniques. And these are some of the common ones. You see there: prompt, cues, incentive, disincentives, goal setting, self-monitoring, and journaling. And to monitor what's going on along the way, patients are rating themselves on a regular basis based on these different components you see here. And then they work with clinicians to establish short-term goals and give feedback along the way so that the treatment plan can be adjusted and monitored and tailored completely to the patient along the way. It's not set from the beginning. There's a starting point based on best attempt to incorporate the biopsychosocial profile into the plan. And this is the last trial I'm going to talk about. This is the biggest undertaking we've done yet. It's with several university collaborations, and it's funded by National Center for Complementary and Integrative Health. They were interested in looking at the value of spinal manipulation as practiced by as a technology practiced not by chiropractors or physical therapists or osteopaths, but without specifically looking at the professions, but as a modality. We wanted to compare that to medical care for patients with the purpose of preventing acute back pain turning into chronic back pain. So all patients here come in with either an acute occurrence of an existing condition that with certain parameters around it, or a new acute back pain, and we then follow them for 12 months using weekly and monthly surveys, and our primary outcomes are pain and disability over 1 year. So again, the whole experience of patients over 1 year. And for assessing the prevention of chronic low back pain, we look at a special outcome measure that's called low back pain impact towards the end of the trial to see if there's a difference between the groups that way. And you can see here we have there are 4 groups, and there's supported self-management group, the spinal manipulation group, and then the combination of the two. And then the medical care is the common comparison to those treatments. We've managed to recruit 1,000 patients who are in the very final months of data collection and ready to write our primary papers. In summary, then, for my presentation here, I would say that modern therapies for back pain is not sufficient. We need them to be multimodal and individualized. They need to contain a major component of pain education exercise and behavioral change techniques to guide self-management. Thank you very much. And I think I now turn it over to Peter for Q&A.
Thank you, Dr. Bronfort, for such a data-rich and idea-rich presentation. I think we're so lucky and fortunate to have someone who's been on the front line for this research for a long time. I'm going to start with one question, and then I'm going to lean on the group to contribute some other questions. There are a few of them that are in the Q&A and a couple that have been lobbed to me via my cell phone. I think the heart of this work is that people with back pain are a very pluralistic population. Not everyone with back pain has the same sources. And it seems that multimodal approaches seem to be more effective in a number of your studies than unimodal approaches, and including this behavioral piece is really key. Are there ways that you can combine your pragmatic research with sort of a better understanding of these mechanisms, whether they're social in terms of group support or behavioral and coaching, or specific modalities, mindful movement versus spinal manipulation, so that you can learn more about how to optimize the team around subgroups of patients? And I guess the follow-up to that, and maybe there isn't a simple question, but this was there, is what does the multidisciplinary team of the future look like?
Yeah, well, let me take the last question first. I think we've come to realize that most patients with back pain, acute and chronic back pain, are still managed in the primary medical care system, and often with an emphasis on pharmacological treatment. And it is probably not the best way to deal with back pain patients, because in a busy medical practice, you see all kinds of patients, and generally primary care physicians are not that fond or well trained in managing back pain. So there are osteopaths, there are chiropractors, there are physical therapists, where this is maybe their main focus, and maybe that's where these more comprehensive methods should be developed, but again, in coordination with the medical physicians, because there's a need for combining it depending on obviously the patient's need. There are very few patients that would say, well, I don't want any medication. Usually they need it at some point to get further and be comfortable helping to manage their own condition. Um, so I don't, I think it's too expensive. And, we have these multidisciplinary teams as tertiary teams where there might be an indication for that and extremely difficult to manage patients. But that's a costly and system with difficult with access. And so probably not the best way to deal with these patients. Now, the other part of your question, do you want to just tell me
Yeah,
again?
I think you pointed to so many different biological, behavioral,
Yeah,
social, maybe even placebogenic mechanisms that are involved in these multidisciplinary teams. And you still get this huge array of responses within an approach. Are there ways of sort of honing in and basically becoming a bit more precise, precision medicine in terms of these individualized approaches? And how will
yeah,
your research move you
yeah.
towards that?
Well, I think the one of the components that's missing here that's not being done very much in back pain, musculoskeletal pain is the genetic profile of patients that hasn't been incorporated that much. And that's probably also an important component to work towards personalized healthcare. So you have all of those factors, and then it's it reminds me a bit of the progress that's been made in cancer therapy. We can't quite transfer this to musculoskeletal conditions, but that's in the genetic realm of really being much more specific with your treatment. So it's a matter of how good can we get at identifying and quantifying those different components of the biopsychosocial model and the behavioral model. Uh, and it's still going to come down to you have to do a little bit of experimentation in each individual patient because you don't know how they're going to respond. I mean, you could look at there's a good chance they'll respond to this with this profile, but this is not specific enough. I'm thinking that there might be some room here for artificial intelligence to help make more sense of this and
Yeah.
automate it more. And we're actually looking to see if we can do some of that work. Um, uh, but so that's my answer.
Yeah. And I think the latter, especially if you can pool people's data from multiple trials,
Right.
and have that power, I think that's going to be the beauty of this collaboration.
Hmm.
I think that's really exciting. I'm going to go to some of the Q&As that are posted. Some of them are very specific. First one was I think this is one of the first studies that you described, but of the 52-week follow-up, was adherence to home exercise assessed? Um, and was the short-term response only during the active period of care?
And which of the
I
which
guess
trial?
I'm not sure that when this one came in pretty early on in your talk, so I imagine it's
Okay.
one of the early ones. But I guess one question in general
Yeah.
is this extra support that you're getting and being in groups, leading to not just the effectiveness of the therapy, but the adherence, which is a key piece here.
Yeah, I mean, adherence is part of it, as I said, for what is clinically important. If people can't adhere to a treatment at all, diminishes over time, then that's a problem. So this is part of the behavioral change techniques that needs to be incorporated. ensuring as high adherence as possible on building that into the behavioral change techniques that are being used. To answer specifically, I don't have the actual numbers, but of it adherence to home exercise, but generally it falls off over time, without a lot of emphasis on adherence in the whole program. This is where the resources the patients can get through websites and apps that are developed to help with that could be very important. And people run into that with trials, adherence, um, doesn't continue on if you lose motivation.
Fantastic. I'm gonna relay another question here. Um, One of our clinicians who's run multidisciplinary teams have said that we've learned that multidisciplinary teams is often not practical or available in many places.
Yeah.
So if that's the case, who's the best first responder to treat and triage back pain patients in these sort of academic settings?
Well, I think I mean it could be um, the people that like physical therapists and chiropractors have focus on that and are primary contact individuals. And they seem to be better suited for that, but it has to be, in an integrated, coordinated fashion. I've always paid a lot of attention to that when I was in practice, that, you don't work in isolation because the patients suffer from that. But currently, I mean, there's been attempts here in the physical therapy world to develop more, mm, effective pathways for dealing with people depending on their risk of chronicity. And so this has been work done in this area, but it, on average, I don't think the two professions are ready yet. They need to be they need to be trained in this kind of model, both for evaluation and treatment for this to have real value as a first contact
Mhm.
entry for patients, and that hasn't happened yet.
But it seems like professions need to continue to evolve and integrate, but some of that requires changes in payment structures and policy. So I'm curious what you think the barriers are to changing sort of clinical parameters and guidelines and reimbursement patterns.
Yeah, that's a good question. I mean, the simple response is the healthcare system is broken in the United States, and it's driven by profit more than evidence. And I don't know how best to change that. I think actually one way to change it and maybe spread from that is through a system like the Veterans Administration, where those things are more common. This integrative care and um, uh, so I th because then there's a reimbursement system for it that you don't have in the general system with all the different
Mm.
health insurance companies and hospital what should I say, hospital um, policies for the importance of staying afloat economically. I mean, so it's the wrong drivers, in my opinion, in the general healthcare system.
Mm. Yeah, I think some big challenges ahead, but I think engaging people in their care may not only help them with their care, but increase their desire to have voice in changing policy as well.
Yes,
I think
absolutely.
as they learn that there is choice in this variety out there, hopefully that can result in some policy and political
Yeah,
change.
so the more independent and self-sufficient patients can get, uh, the better it is for the future and the cost and I think that's
Yeah.
an important component.
And I think in that sense, your emphasis on empowering people with knowledge and self-efficacy in these models is really key.
Yeah.
And I think not just for them, but also for them to, be parts of the agents of change for this healthcare system. So I would like to thank you again for such a remarkable and data-rich presentation and this discussion. I'm surprised I didn't see anyone raise their hands. I was really hoping to have a little bit more direct participation, but I think as we get used to this format, we'll elicit that a little more. I want to finish with just a few comments um, in terms of upcoming events. So I'm going to share my screen again. We hope that you'll be joining us next month for our next grand rounds with Dr. Paula Gardner, who's a graduate of our fellowship. And she's going to be talking about an innovative virtual group visit for caring for and empowering people with chronic pain. And as you can see, this is a very natural extension of this talk today. And Paul has done some really remarkable work developing programs, but also platforms that can create group virtual visits that have education and self-care built into it. Also, save the date for two events. The first is going to be on December 9th and 10th, and we're going to be hosting our next network forum, which is centered on the theme of the intersection of high-tech medicine and soft touch healing. This is going to be really phenomenal. It's going to be here at the Harvard Medical School. We have a number of distinguished international speakers that we're attracting. And as per usual for all our events, this will be open to everybody at no cost. We're excited for that and hope you'll join us. And finally, on November 8th, our team will be partnering with the larger OSHA Collaborative to host a virtual symposium entitled Healthy People, Healthy Planet. And you can learn more about all these programs. You can view archived versions of all of our grand rounds and make a philanthropic donation to help support our initiatives here at the OSHA Center at our website, oshacenter.org. So I want to end by again thanking Professor Bronfort for a phenomenal and content-rich presentation. I also want to thank everyone for your attendance and your participation. Hope to see you all next month.